Welcome everyone. This is the online module for urinary incontinence. So today we're going to talk about stress urinary incontinence, which is probably going to take the bulk of this time together, and then urgency urinary incontinence. We'll touch on treatments, but the majority of discussion of treatments and deciding what treatment to do for what individual we'll go over together in class. So even though we're talking about stress urinary incontinence and urgency urinary incontinence, we really have to put it all together and think about the bladder and urethra as one component with multiple different factors that influence both aspects. So I've probably mentioned this to you before, but I like to think about or divide the bladder into two pieces, right? The bladder and the outlet. And I think that we always need to consider both of these when discussing these problems and when thinking about patient care. So the bladder and the outlet have many different factors that contribute to their function or dysfunction, and I'm just going to list a few of them here. So the brain and the spinal cord, we already went over our neurogenic bladder lecture and talked about this in more detail. Comorbid conditions can affect the bladder and the outlet, such as metabolic syndrome, diabetes, obesity, to name a few. Normal aging has effects on both the bladder and the urethra. Pelvic floor and childbirth, also hormones in females in particular. Cancer and radiation can negatively affect the bladder and the outlet. Of course, prior surgery and bowel movements are intimately linked to bladder function. So I just want to put this out here as a starting point. We're going to be breaking things down into specific components and diseases, but really I want to make everybody aware that when we're thinking about these problems, we need to think about all of these things concomitantly. So stress and urgency urinary incontinence are very common in women, and depending on what study you look at, it's anywhere from 5 to 72% of women, huge range there. And there's a lot of overlap, so you don't necessarily have to have one or the other, but you can have both, as shown in this Venn diagram here. And this is a often quoted or often used illustration that I think is really helpful, looking at the prevalence of urgency and stress incontinence by age. And you can see here on the bottom line that the prevalence of urgency incontinence increases with age, and the prevalence of stress urinary incontinence decreases with age. But overall, as indicated on the either line, where you can have one or the other or both really, the incidence altogether goes up over time. So these are very, very, very common problems. So we're going to start with stress urinary incontinence, and just as a note, I'm going to focus this talk on women. So everything that I'm talking about today really is in relation to women. Men are a little bit different. So, as we all know, stress incontinence and all incontinence negatively affects quality of life. And stress incontinence and pelvic floor disorders in women account for $19.5 to $26.3 billion per year in annual expenditures. And they're very common conditions. 28.1 million women are projected to have a pelvic floor disorder in the year 2010, and this is projected to go up to 43.8 million by the year 2050. So huge problem, huge expense, and huge utilization of resources related to these conditions. So starting with the pathophysiology of stress urinary incontinence in women, the mechanisms are not completely understood. And the thought is that incontinence, stress incontinence, probably doesn't result from any one single factor, but rather from a combination of factors. And in order to be continent, you need to have normal function of the peripheral and central nervous systems, the bladder wall, the detrusor muscle, the urethra, and pelvic floor musculature. So again, there's a lot that goes into play here. So I'm going to break it down a little bit. We'll start by talking about urethral support. Again, this is in women. And the anterior vaginal wall support, it's thought directly impacts urethral support. The anterior vaginal wall is attached to the arcus tendineus fascia, which is this gray line here, and it's really a condensation of the levator ani fascia, arising from the surface of the levator ani muscles. Okay, and this is going to be very important in our understanding of stress urinary incontinence. The point of attachment of the levator ani and the obturator internus muscles is right here on this arcus tendineus. So it's sort of the converging point of a lot of the pelvic floor structures. So we need to have intact support of the bladder neck and the proximal urethra in a retropubic position for maintenance of urinary incontinence under stress. And this emphasizes the importance of a stable and intact pelvic floor, or the arcus tendineus, like we talked about. And there's also a stable suburethral layer of anterior vaginal wall that prevents urethral and bladder descent, leading to leakage, leading to urethral compression with straining. And this idea is the basis of some of the older retropubic operations that you may or may not have heard of, called, one of them is called the MMK, or Marshall-Marchetti-Kantz urethropexy. There's several others in this category, but basically what those involve is, you can see here in the illustration, you're basically pexing up the periurethral fascia here to the pubis symphysis to sort of elevate the position of the bladder neck, or the proximal urethra, into that retropubic space. So a little bit about the levator ani. It can be made stronger with pelvic floor physical therapy, so that's what's being focused on with that technique. And they include 3 different muscles, which are illustrated here. So the iliococcygeus, the pubococcygeus, and the puborectalis. And it's really the pubococcygeus muscle that pulls the bladder floor tightly up into the pelvic cavity and helps with continence. This also renders a firm backboard for the urethra during stress maneuvers. So the levator ani it is thought, have a dual role to prevent incontinence. So one is they provide the resting urethral tone and assistance support, and these are slow twitch fibers, muscle fibers. And the second is they contract rapidly with increased intra-abdominal pressure, and these are the fast twitch fibers. So next we're going to talk about urethral coaptation. So as you all know, the urethra is a pliable structure, and the lumen must be completely sealed or coapted in order to maintain continence. And the urethral wall must be sufficiently soft so that external forces can act on it to effect closure. And a thick urethral wall, it's been demonstrated, does not coapt. So this is, for example, what you would see with radiation damage, and this is referred to as ISD, or intrinsic sphincter deficiency. And it's also used to be called the lead pipe urethra. So it's sort of a stiff, fixed urethra, and it's open, and it's fixed open, and so it doesn't coapt, and it's very difficult, or can be difficult to treat. This is something that urethral bulking agents attempt to address in order to sort of plump up that urethral tissue to help it to coapt. Okay, and finally the urethral sphincter. So I think this is largely misunderstood, and our understanding of it is still growing, but our simplistic understanding is that there are basically 2 sphincters. One is the internal intrinsic sphincter, which is under autonomic control. That's more of a functional sphincter than an actual anatomic sphincter. And the second is the external urethral sphincter, which is under somatic control. Now, a couple of theories on how we maintain continence, and these theories are of great historical significance, but they're also practical because they form the basis for our current treatments of stress urinary incontinence, mainly the midurethral sling. So there are 2 main theories. One is the integral theory and the other is the hammock theory, and I'm going to explain them both right here. So starting with the integral theory, this was introduced by Petros and Olmsted in 1990. And they describe in their manuscript that stress and urge symptoms both arise from the same anatomic defect, a lax vagina. So they believe that the vagina has a dual role in transmitting voluntary and involuntary muscle contractions involved in bladder neck and urethral closure. And this theory is based on pelvic anatomy and their understanding of pelvic anatomy. And so they believe that there's a pubourethral ligament that acts as a fulcrum and sort of suspends up the midurethra to the pubis symphysis. They also discuss 2 normal urethral closure mechanisms, one being the urethra and one being the bladder neck. And the third mechanism that they discuss it exists that is not normally necessary, but can be recruited with pelvic floor exercises when other mechanisms fail. So this is sort of some more of the external pelvic floor musculature. And then there's this diagram, and clearly there is a lot going on here, but I'm just going to point out two things to help illustrate this theory. So the first is these two dashed arrows in the circle represent sort of the idea that they stretch the vagina hammock against the anterior ligaments to close off the urethra from behind. And these are sort of that mid-urethral ligaments that were mentioned on the previous slide. This is using the word hammock, but in a different way than the hammock theory uses it. So consider those two completely different concepts, even though they're the same name. I know it's a little bit confusing. Okay, so you can see these vectors of the pubourethral ligaments going upwards at the mid-urethra, and then there's a couple of other vectors in this figure here, and these stretch the mid-zone of the urethra against the anterior ligaments to pre-tension the vaginal hammock, again, different use of the word hammock, and to assist in bladder neck closure. So basically what I want you to get from this picture is that these arrows are vectors moving in different directions to help sort of coapt and close the urethra to help prevent stress urinary incontinence. So it's the integral theory. There's a lot of different vectors going on based on different understandings of anatomical support of the urethra. Okay? And that's to be contracted with the hammock theory, which I'll discuss now. So that was developed by John Delancey. The urethra and the bladder neck, and the idea is that the urethra and bladder neck rest on the anterior vagina that is itself suspended by fascial attachments to the levator ani muscles of the arcus tendinous fascia. Remember, that's that gray line that I showed you on that anatomy slide a few slides back that everything is connected to. And it's the loss of this hammock-like structure support that leads to failed urethral compression during times of stress. So on this left image here, you can see the vaginal hammock is represented here with these lines, and this is the arcus tendinous up here. So you can see if one of the sides of this vaginal hammock fell off, that there would be no backboard here for the urethra to compress against during stress. And this is shown here on the right in sort of more of a cartoon, showing that the hammock basically falls down. So I want to draw your attention to the AUA guidelines, which were just re-presented in 2017. And we're going to go over this more in our in-class discussion. But just to lay the framework, this is the evaluation per the guidelines for female stress urinary incontinence. So initial evaluation includes a history of physical exam, demonstration of stress urinary incontinence, that is key. PVR assessment, you need to do that to make sure that there isn't something else going on, that somebody isn't emptying their bladder very well. That would affect the treatments that you would select, and a urinalysis. Cystoscopy should not routinely be performed unless there's a separate indication to do so. And urodynamics does not need to be performed unless the picture is more complicated. So for example, if you weren't able to exhibit stress urinary incontinence on exam, remember you do have to see that, so you need to figure out some method to see the leakage. And if there's something else going on or if the diagnosis is unclear. So that leads us to this box on the right. Additional evaluation should be performed if there's a lack of a definitive diagnosis, inability to demonstrate stress urinary incontinence, some other abnormalities or known or suspected neurogenic problems, urgency predominant mixed incontinence, elevated post-void residual, high-grade prolapse, and evidence of significant voiding dysfunction. And then moving on, these guidelines are illustrating the treatment options, and again, we'll go over these in more detail in our class together, but briefly, non-surgical treatments include a pessary, a special continence pessary, and these pessaries have a little continence knob that actually physically compresses the urethra. Vaginal inserts, there's some that are available commercially. Pelvic floor muscle exercises. And then surgical treatments include bulking agents, mid-urethral slings, and there's a little side note here that you can use either a transobturator or retropubic. If you're to use what's called a single incision sling, you have to inform your patients that there's not as good evidence for their efficacy and safety. An autologous pubovaginal sling, and a birch copal suspension. All right, so that's our section on stress urinary incontinence, and now we're going to move on to urgency urinary incontinence / overactive bladder. So the terminology here is important. Overactive bladder, urgency is defined, or urgency incontinence, is defined as urgency with or without urgency incontinence, usually with increased daytime frequency and nocturia, if there is no proven infection or other obvious pathology. And this is a definition that's widely used by the International Continence Society. So the part of this that is important is you need to rule out other pathologies such as bladder cancer, urinary tract infection, or something else that would give these symptoms. Now, the distinction that is important is between overactive bladder and detrusor overactivity. So overactive bladder is a symptomatic diagnosis. So it's a constellation of symptoms and you make this diagnosis based on the patient report. DO is detrusor overactivity, and that's a urodynamic observation. So that diagnosis can only be made if you see detrusor contractions on a urodynamic study. And this graph is showing the prevalence of overactive bladder increases fairly equally in men and women as they age. And here is a cartoon showing the effects of overactive bladder. So as I'm sure you all are familiar, the bladder is a muscle. The purpose of the muscle is to squeeze or contract when you want to urinate. And when the muscle squeezes or contracts when you don't want to urinate, it can give you a feeling of urgency and make you feel like you need to run to the bathroom. And sometimes that can be associated with leakage. So I want to draw your attention to the AUA guidelines that exist for overactive bladder. And I encourage you all to look at these at your leisure, but I'm going to give you a couple of slides here that are straight out of the guidelines on the diagnosis of OAB. So one, the clinician should engage in a diagnostic process to document symptoms and signs that characterize OAB and exclude other disorders that could not be the cause of the patient's symptoms. The minimum requirements for this process are careful history, physical exam, and urinalysis. In some patients, additional procedures and measures may be necessary to validate an OAB diagnosis, exclude other disorders, and fully inform the treatment plan. At the clinician's discretion, a urine culture or post-void residual assessment may be performed, and information from bladder diaries and/or symptom questionnaires may be obtained. Urodynamic, cystoscopy, and diagnostic renal and bladder ultrasound should not be used in the initial workup of an uncomplicated patient. This here is key, and I could certainly see them asking you questions about this. OAB is not a disease. It's a symptom complex that generally is not life-threatening. After assessment has been performed to exclude conditions requiring treatment and counseling, no treatment is an acceptable choice. This is also an important thing to keep in mind. And clinicians should provide education to patients regarding normal lower urinary tract function, what is known about OAB, the benefits versus risks and burdens of the available treatment alternatives, and the fact that acceptable symptom control may require trials of multiple therapeutic options before it is achieved. And I think this is key, because I think it's really important to set up those expectations for patients and tell them, it may take a couple of tries, we may have to try a couple of different medications or therapies or techniques before we get to the right one for you. I find that very, very helpful. So here is the OAB algorithm from the AUA, and this is pretty complicated looking, but it's really, really pretty straightforward. So you start with a history and physical and urinalysis, and then go on to patient education, behavioral treatments, and then pharmacologic management. You can use anticholinergics or beta-3 agonists, and if those things don't work, then you can consider what are called third-line therapies. So one of them would be Botox, another would be PTNS, percutaneous or peripheral tibial nerve stimulation, and finally sacral neuromodulation. So just a few things on some of those therapies. Here is a cartoon of the bladder and how the medications work on the bladder. We'll start with the anticholinergics, which are shown at the top here. So you can see there are 6 or so different anticholinergics, and there aren't huge differences between them. Oxybutynin is always considered to have the highest risk or adverse event profile, and the guidelines actually say that they prefer any extended release option over any immediate release option. So for acetylcholine, you can see that there's, on the top of the bladder here, there is a receptor. This is an M3 muscarinic receptor. Acetylcholine binds into this receptor and causes a detrusor contraction. Antimuscarinics act in this receptor to block the binding of acetylcholine and hopefully the initiation of this bladder contraction. Okay. Then we have over here beta-3 agonists, and this is mirabegron. It's the only one on the market currently. And this works in a different way. So so norepinephrine binds to receptor here on the bladder and causes actually relaxation. So the opposite of the anticholinergic, it relaxes the bladder. And the beta-3 agonist is sort of augmenting this relaxation of the bladder. So the two, it's sort of, I think about it as a push-pull mechanism. They're working in different ways to get to the same end result of relaxing the bladder. And for this reason, you can use one. If you use one and it doesn't work, the other one may work, and vice versa. You can also potentially use both in the same patient because they do work differently. And just to point out here, as a transition to our next slide, is Botox also works at the acetylcholine mechanism. So we're going to go over that next. So here is a diagram of how Botox works. So first, let's start on the left side. And the famous snap-snare proteins are delineated here. And this is in a neuromuscular junction without Botox. So this is normal neurotransmitter release. And you can see that the snap-snare proteins bind to this vesicle, which is filled with acetylcholine. And they basically allow exocytosis here to allow the acetylcholine to be released so that it can bind on the acetylcholine receptor on the muscle cell. So that's what normally happens. On the right side, this is what happens when Botox is present. So this gray area here denotes the light and long chain of the Botox toxin. It binds to the cleft here, gets internalized, and the light chain actually cleaves the snap-snare protein. So without that snap-snare protein, the acetylcholine is trapped inside the vesicles in the axon terminal of the nerve and can't be released into this space here, and therefore cannot bind to the muscle cell. And sacral neuromodulation, I'll touch on very quickly. As many of you have know and have performed with me even, we place the electrode in the S3 foramen through the low back. The mechanism isn't fully understood, but it's believed that the stimulation to the S3 nerve, which is the nerve that goes to the bladder and the bowels, affects the afferent signaling and hence the activity of the bladder contractions. This is FDA approved for frequency, urgency incontinence, neurogenic retention, and fecal incontinence. And we can't predict who it's going to work well in and who it isn't going to work well in, so we do it in a staged approach. The first stage is the test phase, where we implant the lead, and they go home with an external pulse generator for anywhere from 1 to 2 weeks and test it out. If it works, they come back for stage 2, and we implant the IPG, the pulse generator or the battery, under the skin, and if it doesn't work, we still bring it back to the operating room to remove the lead that was placed. So that concludes our talk today on stress urinary incontinence and urgency urinary incontinence. And we'll use this as a framework to go a little bit deeper into some cases and discussion when we come together as a group in person. All right, so I look forward to continuing the conversation.